Okay, welcome everyone. So now we are going to start a very interesting topic, and that is postpartum hemorrhage. It is a condition in which excess blood loss occurs after delivery. That's why we call it postpartum hemorrhage. There are three types of postpartum hemorrhage. Number one is early primary postpartum hemorrhage, and second is secondary late postpartum hemorrhage or massive obstetric hemorrhage. And primary early postpartum hemorrhage, in which blood loss is greater than 500 milliliter within 24 hours after delivery, while secondary is between 24 to 6 weeks of delivery, and massive obstetric hemorrhage, in which blood is greater than 2.5 liter of blood is lost, that is massive obstetric hemorrhage. Now the causes for postpartum hemorrhage are uterine atony. Most important cause is uterine atony, macrosmia, prolonged labor, oxytocin use, induction of labor, or other causes include retained products of conception, placenta previa, placenta accreta, genital tract trauma, coagulation disorder, and prior multiple C-sections. Now, uterine inversion and uterine rupture are also causes of postpartum hemorrhage. So, if the hemorrhage occurs, then hypovolemia will be there, and hypovolemic shock will be there in the patient. So, hypovolemic shock will present with patient will present with anxiety, thirst, cold, dizziness, unresponsiveness. Signs will be tachycardia, urine output will be reduced, tachypnea, and increased respiratory rate with hypotension and reduced pulse pressure because of hypovolemia. So the management of this condition will be ABCDE protocol or primary survey, in which airway is maintained, breath is maintained, circulation and drugs should be given to the patient. So ABCD protocol, primary survey should be maintained for the patient, and massage the uterus with bimanual compression and remove any clot if any placenta previa or the retained products of conception are there. So uterotonic agents like oxytocin should be given, and rectal misoprostol should be given with centometrine, and carboprost should be given to the patient. So in this way we can manage the patient for bleeding if surgical options are required. So uterine artery embolization is done in order to prevent blood loss, iliac artery ligation, uterine balloon insertion, and finally hysterectomy, removal of some parts of uterus should be done in order to prevent blood loss. And the another condition is uterine rupture or uterine inversion. Uterine rupture occurs during labor but has been reported antenatally. Now, risk factor for uterine rupture are prior C-section, are congenital abnormalities of the uterus, use of oxytocin, failure to recognize obstructed labor can help to prevent this condition. Now, the sign symptoms for this condition are sudden onset abdominal pain with the fetal parts are palpable, recession of presenting parts of the fetus, fetal distress, vaginal bleeding occurs. Management will be maternal resuscitation with urgent lower segment C-section to deliver the fetus because uterine is going to be inverted. Vaginal delivery of fetus can be considered if cervix is dilated, followed by laparotomy and repair uterine rupture. Now, uterine inversion. In this condition, what happens? Descent of uterus fundus into uterine cavity occurs below. So, as you can see in this picture, this is uterine inversion, figure of uterine inversion, in which uterus is coming out through cervical opening. Four stages of this condition are there. In stage 1, inverted fundus extend into cervix. In second stage, inverted fundus extend through the cervix but not into the vagina. In third stage, and inverted fundus is extend outside of the vagina, while in fourth stage, the vagina and uterus are completely inverted. So, if this condition is taken place, what can be the risk factors or causative agents for this condition? Risk factors are full dilated C-section, malpresentation, prolonged second stage abnormal adhesion of placenta, short cord, previous uterine inversion, or strong traction of umbilical cord with excessive fundal pressure. Management for this condition is call for help, obstetric hemorrhagic protocol should be given, ABCD should be maintained for the patient, relax the uterus, stop uterotonic agent and consider tocolytic drug with hydrostatic repositioning, and the surgical procedure includes surgical procedure, and hysterectomy. If all procedures fail, then hysterectomy is the only treatment. So in this way, we can prevent uterine inversion. So the another postpartum complication is amniotic fluid embolism, and this is very simple disease or a condition can develop in which embolism comes into venous and that converted into the thrombus and then goes into the pulmonary veins. Pulmonary venous thrombosis develops, and patient may present with dyspnea, collapse, syncope, and loss of consciousness, and eventually maternal mortality can occur because of this. So the another condition is shoulder dystocia. It is a condition in which difficulty with the delivery of fetal shoulder can take place. It is an obstetric emergency, has potential for serious fetal complications. Risk factors are antenatal risk factors include large baby, Mcqs baby, or small babies, or previous shoulder dystocia, diabetes mellitus mother, or post-term pregnancies can give rise to this condition. Intrapartum complications include prolonged first stage labor, induction of labor, prolonged second stage of labor with instrumental or vaginal delivery, or oxytocin augmentation of labor can take place. Complication or maternal complication includes postpartum hemorrhage, genital tract trauma, and birth. Fetal complications are brachial plexus palsy can occur to the fetus, fracture of the clavicle, fracture of uterus, hypoxic brain injury, and intracranial hemorrhage can occur to the baby. So the management for shoulder dystocia should be remembered with the mnemonic of helpers. Helper. Okay, help means H for help, call for help, and E for episiotomy is performed in order to deliver the baby because baby has gotten large size, and L for microbird position. Legs should be in microbird's position, like hyperflexed at hips and with the thighs abducted. And P for suprapubic pressure should be applied. E for interpelvis into manual position. And the last one will be R. Release the posterior arm with flexing elbow, and finally last R should be roll over to all four may help in aiding delivery. So in this way, helper can relieve this can treat this condition of shoulder dystocia. So in this way, we can manage this condition of shoulder dystocia, and we can save the life of fetus. Now, the last and most important post-operative or the postpartum complication is cord prolapse. It is a condition in which umbilical cord descends through cervix along with the presenting part of in the presence of rupture membrane, in which umbilical descent of umbilical cord into the cervix occurs. Abnormal live presentation risk factors are abnormal live presentation, multiple pregnancies, polyhydramnios, low birth weight baby, whose weight is less than 2.5 kg, internal podalic version babies. Management should be suspected and perform a speculum or digital examination, and then urgent C-section is required for cord prolapse babies. Cord compression can be prevented by knee to chest position, fill the bladder with a 500 milliliter warm normal saline and hand into vagina to push the presenting part, and before C-section listen the fetal heart sound and make sure that if fetus is alive or not. During C-section, avoid handling the cord, avoid hypothermia, and give tocolites to the mother in order to save the life. So in this way, cord prolapse can be treated. So in this video, we discussed all postpartum complications like cord prolapse, shoulder dystocia, and postpartum hemorrhage. So these were major complications can take place after delivery of the baby, and we have to manage the life of baby as well as the life of mother in order to ensure the safety and prevent mortality in both of them. So this was all about. In other videos, we will also discuss antepartum hemorrhage and preterm pregnancies and pre-labor rupture of membrane and other complications as well.